Well, the title of this, From Shaking Palsy to Synucleinopathy, tells us a little bit about the voyage. We're going to take 2 centuries of history on Parkinson's disease, and we'll try to capture some of its identity in the following slides. Back in the early 1800s, somebody carved this little figurine in a Swedish hotel that I ran into. It describes what we know about the identity of Parkinson's. It changes your posture, it changes position of hands, but it certainly has a much more important change in the quality of your daily functioning. And that's what I'll try to get into in this short lecture. Back a little more than 200 years ago, a small-town doctor named James Parkinson described a condition that he called the shaking palsy. And in this essay, published in 1817, he described this condition so well that today we could identify what he was talking about in the 6 patients that he described. For example, he described the tremor, the slowness of movement, and other things that people with Parkinson's disease live with on a daily basis. In this essay, he describes the condition as having features of involuntary tremulous motion with lessened muscular power, in parts not in action, and even when supported. And the rest of this description is one that we'll see even in modern textbooks of this condition and people living with Parkinson's experience in some measure. So what is the identity of Parkinson's disease today? Much as in James Parkinson's time, it's a disorder that doesn't affect everybody. It's not inevitable with normal aging. And it's a seemingly sporadic disorder that somehow is related to life experience. We'll talk about what we know about its causation, but it seems to be a combination of factors of environment, that is one's life's experiences, and possibly genetics as well. It's a movement disorder for the most part, at least to people living with it, and it has a clinical syndrome that comes from the brain, but it has evidence for being systemic, that is, widely distributed throughout the body, even in the small intestines, in the heart, in the skin, and we'll talk about some of those clues as the lecture goes on. It's possibly a condition that has multiple causes, but we really don't know exactly what initiates it for most people, and it seems to have a final common pathway leading to a misfolded protein that's in every cell of the body, and we'll talk about that protein, which is called alpha-synuclein, which is misfolded, that is, not in its normal molecular structure. So let's start out from the beginning. The cardinal signs, the key features of Parkinsonism are listed here. Now, Parkinsonism is a clinical syndrome, which is often a constellation of signs and symptoms of motor impairment, sometimes just a few of them, or even just one in some patients. For example, bradykinesia, slowness of movement, as we'll talk about, can be the only feature in some people without the tremor that is often regarded as a core feature. So let's look at these signs and see what they really mean when a physician rattles them off to you. Bradykinesia, from its original linguistic roots, means slowness of movement, but it's much more than that, and people living with Parkinson's have impaired motor control that's characterized by slowed movement, decreased dexterity, loss of synchrony in movements. That is, fine dexterity can be decreased in such tasks as handwriting and so on. And repetitive tasks like handwriting or just tapping the fingers can also decay in the ability to continue. Rigidity is defined as increased muscle tone, typically in the limbs or in the neck muscles, and sometimes there's a ratchety quality which is termed cogwheeling. The question of tremor has a differential diagnosis. That means a patient who has shaking in the hands or elsewhere might have multiple different causes, but in Parkinson's disease, this repetitive rhythmic kind of movement is often there at rest, going away during actions. And sometimes it's seen with the arms extended as well, or it can even be just an internal sensation of tremulousness without any outward indications. So in Parkinson's disease, and many who are living with this know the early onset symptoms very well, sometimes there's nothing at all that tells you you have Parkinson's, but something is wrong. And a study of this disorder has shown that other things can show up long before these motor symptoms begin. For example, sometimes an impaired sense of smell or acting out dreams at nighttime or an increased risk for Parkinson's precedes any of the motor symptoms of Parkinson's. I'll show you the timeline of these typical problems, but they can be years out before the motor symptoms begin. When it emerges as a condition that someone is experiencing or those around them recognize for it, it can be slowed gait, it can be slowness in general or decreased arm swing in everyday activities. Other things that can be a tip-off to Parkinson's can be decreased facial expression or a softer voice or trailing off of the voice or handwriting as early features, sometimes months before anything else evolves. Motor symptoms are sometimes just on one side. The slowness of movement or tremor can only affect one hand in some people, and oftentimes there's just a single symptom, such as tremor. But eventually, some people have a combination of these evolving. Early on, there can be other things that go beyond the symptoms mentioned above, for example, cramping of the feet or deep aches in the limbs or sensations of altered temperature. These can also be early and very nonspecific features. Someone might think that their lack of arm swing might be due to a frozen shoulder when in fact it's the earliest feature of Parkinson's. And it's important to remember that for many people the onset is subtle. It can be hard to recognize as even impairment because it can vary from day to day or even hour to hour. Sometimes symptoms such as tremor are brought out by stress. So not everything that fits the bill for that, this very nebulous kind of condition, is necessarily Parkinson's disease. And in fact, we in the medical business are always looking for the alternative causes. These are some of the diagnoses that can mimic Parkinson's disease that are acquired and yet aren't the same thing as the disorder Parkinson's disease, as I'll define it in a few moments. For example, drug-induced blockade or depletion of a particular chemical in the brain called dopamine is one of the ways that Parkinsonism, the syndrome we described above, can be acquired. Encephalitis, an infection of the brain by viruses or bacteria, is sometimes a cause for Parkinsonism that is different than Parkinson's disease. There are certain toxic exposures out there in the environment. I'll show you one cause of that, which is carbon monoxide. Otherwise, Parkinson's can be due to various structural problems in the brain, especially when it's there in one-sided form. A stroke, a tumor, or a large blood clot can be a cause. And so you can imagine taking a picture of the brain with a scan might be useful in some instances. Another condition that we often look for because it has an alternative treatment is communicating hydrocephalus, which means the fluid chambers of the brain can be enlarged and need to be shunted. This condition is often abbreviated as NPH. Failure of the liver can cause Parkinsonism, and there's some rare metabolic disorders listed here that can also lead to it. In short, there's a differential diagnosis, and physicians, especially facing a new case of Parkinsonism, want to look for these things because they have other treatments, other implications. And here's an example of a brain scan that shows with the arrow pointing to a particular little change in the brain. Those little black dots on both sides refer to the effects of chronic exposure to carbon monoxide, someone who worked in a poorly ventilated factory who developed Parkinson's symptoms, but it wasn't Parkinson's disease, it was the result of this exposure. So there's always reason to meet with a neurologist to get a definitive diagnosis of Parkinson's amongst all the other possible causes. And here are listed some of the neurodegenerative conditions that can mimic Parkinson's disease. I don't want you to take these all in, but it's important to remember that other conditions can have some of the features mentioned above, which really have a different identity and in some instances have different treatments. And the list gets even longer. I don't want to belabor these points, but it's of interest to know that even a genetic disorder or two is on this list. There's also a form of Parkinson's that occurred between 1917 and 1928, encephalitis lethargica, which we don't see anymore, but back in that era accounted for up to 50% of people who had the syndrome of Parkinson's disease. So it's a changing condition over the years. And what we've also learned about it, it's more than just a motor disorder. It's more than that slowness of movement or tremors or rigidity. And in fact, we know that the loss of nerve cells that cause those problems can cause some other mischief in the brain as it evolves. And I'll try to give an overview of that in the next few minutes. Now let's go back to Parkinson's disease. What does disease mean in this context? Well, it means that there's a set of clinical problems, slowness of movement and tremors and so on, but they're linked to something going on in the brain. And in this instance, the part of the brain is called the brainstem. And on the left you see the normal brain structure, and on the right side, which evidently has something different. You can see those black stripes there with the arrow pointing to a substance called the black substance or substantia nigra. This is an area to the naked eye that differentiates Parkinson's disease, because on the right side in the Parkinson's brain specimen, they're missing the large proportion of those nerve cells. This is sort of the main structure of the brain where Parkinson's disease originates. And what's going on in there is a degenerative process that probably takes years to occur, and the consequences of that have been pretty well determined. What is the neurochemical outcome of that? Well, it's a loss of a chemical called dopamine, which is an important signaling compound. So Parkinson's disease can be defined as a dopamine deficiency disorder, especially in that part of the brain. So the important thing about that loss of cells is that the signaling between nerve cells is impaired. The ability to move or not have tremor is directly linked to this finding. And let's take a look at what that involves. Well, this is an imaging that can be done in the clinic. It's called a PET scan, and we have another similar kind of study called a Spect Scan. And what you see here in comparing the normal side of the brain with the Parkinson side is that a particular region called the striatum has lost some of the activity. The bright red central portions in the normal brain are lost by and large on the Parkinson side, and that goes along with the loss of dopamine. So we can actually see in the living person the consequences of having Parkinson's in terms of the chemistry that's responsible for the symptoms. We can prove somebody has the dopamine deficiency without having to get inside the brain. And one of the consequences of losing nerve cells is that you have something forming called the Lewy body. And here I have illustrated a microscope picture of brain tissue, which shows with the arrows these bullseye-shaped structures, pink because of staining here, but in reality just portions of nerve cells that are distinctively different than the nerve cells clustered around there. And the formation, the pathogenesis of Parkinson's disease is very closely linked to the formation of Lewy bodies. And these Lewy bodies, these structures that evolve in every case of Parkinson's disease, are composed largely of alpha-synuclein. Now, alpha-synuclein is a normal protein present not only in our brains but throughout our bodies, but when it is abnormally clumped together, it forms these structures, which you can imagine as strangling the nerve cells, and the loss of nerve cells is directly proportional to the amount of Lewy body formation with alpha-synuclein. And here at the bottom slide is a picture illustrating what's going wrong in Parkinson's. Virtually every case of Parkinson's disease has misfolded protein, and that's illustrated in the transition from the picture on the left to the picture on the right. The folding of proteins has to be exactly right for nerve cells and cells all over your body to function properly. And when they become gummed up by misfolding, the turnover that is natural for proteins ceases to happen, and those cells more or less become strangled by byproducts of normal metabolism. At least that's what our current understanding of Parkinson's is all about. Why that happens is a story unto itself, but we'll touch on to that in just a few minutes. But in any case, one of the revolutions in the 1990s about learning of the identity of Parkinson's disease is the fact that this is a core final pathway of what goes on in this disorder. So here's just some illustration of staining nerve cells for alpha-synuclein in different brain tissues, and you can see how impaired those cells must be to have all this stained stuff in the dark brown throughout the portions of the brain that are affected. Now, another revolution that's occurred in the past 20 years in Parkinson's disease is recognizing that it is a migratory disorder. That is, it starts in one portion of the brain, or several portions that is, and moves on to the motor areas. And in the middle panel here is an illustration of a side view of the brain showing the motor disorder in sort of a later stage than the stage on the left, which is the earliest inklings of Parkinson's disease. Recall that I mentioned that the loss of sense of smell is sometimes a forerunner of the disorder. Well, the arrows on the left indicate the portion of the brain, the olfactory region, the sense of smell, that oftentimes can precede the onset of Parkinson's by 5 or more years. As many as 30 to 50% of patients have some degree of impaired sense of smell long before anything else seems to have gone wrong. And you can see the lower portions of the brain are sort of in a pinkish coloring there. And that also goes along with portions of the brain having to do with regulation of sleep and other functions, so that some of the symptoms of disordered sleep that I mentioned, acting out dreams, or sometimes impaired blood pressure control, or flushing, or excessive sweating, can be attributed to that portion of the brain long before tremors or slowness of movement arise. So several years later, the middle stage of the disease is illustrated in the middle portion, and unfortunately Parkinson's for some patients can progress beyond that to affect parts of the thinking areas of the brain or other regions that have to do with different functions. And I'll touch on those in a few moments. So this hypothesis by a researcher named Brock has been very important in influencing how we might treat the disease, how we might cure it, because the notion that it starts in locations independently of the motor symptoms and might spread over the years gives us the notion that perhaps we can diagnose it early and stop it in its tracks. One of the concepts that has come out too in recent years is that Parkinson's disease has a number of non-motor features. We touched on the sleep disorder, difficulties, for example, in blood pressure regulation and so on, and some of these things are illustrated here. Depression, anxiety, insomnia, daytime sleepiness, dysfunction of how one's bladder works, and so on. All of these things listed in the sides of these slides suggest that tip of the iceberg that is Parkinson's disease has underneath the water there a number of other potential non-motor features that seem to go along with Parkinson's, and as the years go by can be some of its biggest problems. Fortunately, we have treatments for some of these. For example, excessive drooling can be helped with medication approaches to lessen that, and sleep can be helped in different ways, as well as problems of short-term memory or bladder function. But these are part of the spectrum of Parkinson's that evolves over time in many people, sometimes in the course of the first few years. And so I've put on this graph here a sense of the phases of Parkinson's disease, not linked to any particular time span, because everybody with this disorder has different symptoms and is a little bit different in whether it evolves or worsens over time. But you can see on the left the onset phase, where perhaps the loss of sense of smell or disturbance of sleep, or perhaps nothing at all is happening, perhaps decades before. This is, of course, the time when we'd want to cure the disorder, or at least have the ability to diagnose it to know what's coming. In the middle stage there, with the rise of the graph of diagnosis coming out, the important thing there is that this is when motor symptoms are there. This is when today diagnosis is made, even though you might even think it's advanced by several years at that point. And then in the later stages is when those non-motor features might evolve. For example, problems of smell, problems of sleep, problems of balance, and so on. So it is a disorder that has distinct phases, and perhaps one of these days we can get to the far left of this graph at the onset and perhaps prevent it from even evolving. Now, one of the interesting things, emphasizing the systemic nature, that is, every part of the body somewhat affected by Parkinson's, is taking some of that information about alpha-synuclein and showing that, in fact, there is a way to diagnose it outside of the brain. This is just some interesting information that came from studies of colon biopsies, patients who had routine colonoscopies, and then a few years later turned out to have Parkinson's disease. Well, by staining for that same protein I mentioned earlier, alpha-synuclein, you can find clues in the Parkinson patients that they had small amounts of this deposited in the nerve cells of their lower GI tract, the colon. And indeed, this is years before the onset of any motor symptoms, suggesting that somewhere else in the body you can find clues for this. Similar research is going on in skin biopsies of people who went on to have Parkinson's disease, and so there may be ways to find biomarkers, that is, different ways to diagnose the condition without having to have the primary symptoms. So since we're on the topic, what causes Parkinson's? And all I can offer to you is a very colorful set of slides from here on in. We have a great deal of information that research has brought us, and in these different boxes are at least the concepts of what might be tied into the causation, the etiology of Parkinson's disease. And different patients may have a different mixture of each of these. It may be that there are multiple causes. Certainly environmental toxins have been sought for, and modern epidemiology does recognize that certain kinds of exposures seem to increase your risk for Parkinson's or decrease it. For example, cigarette smoking lowers your risk for Parkinson's. A low uric acid level, one of the chemicals in our bloodstream, increases your risk for Parkinson's. So there are some things that come from our diet or habits that we have in life that might have an influence. But by and large, there hasn't been anything that's come out to strongly suggest stay away from that or get more of that. So that's one of the key understandings we have at the present time. We also know that normal aging is probably the major risk for Parkinson's, which begins in one's 50s typically, although it can begin younger than that, and for some people it holds off in its origin to one's 60s, 70s, 80s. But in general, aging is a major factor because it's extremely rare to develop Parkinson's under the age of 30, and even in the age range of the 40s to 50s, only about 5% of patients who have this disorder had the first beginnings of symptoms at that time. However, there may be some mechanisms of vulnerability that come out, and that's what the rest of the slide indicates. For example, there is evidence of oxidative stress, and this is recognized as that pink middle box, lipid peroxidation. There clearly is a relationship to something that is damaging to cells related to active oxygen species, which may be part of impaired metabolism. There is evidence in Parkinson's of the protein impairment that it was illustrated with the misfolding of that protein alpha-synuclein. There's also evidence that DNA somehow doesn't function properly, the mastermind molecule of cells. So there are a lot of things going on which may be epiphenomena that is occurring after the disease begins, or they may be core features. And at the present time, it's been very hard to sort out what leads ultimately to the bottom picture there, cell death, which is the loss of cells clumped up with those Lewy bodies that we showed on earlier. But one of the revolutions that's really changed Parkinson's in the past 2 decades has been recognition that there are rare cases in this world that is clearly caused by genetic factors, that it's an inherited disorder in those rare families of the world. And what's illustrated here in that circle are the genome, that is the genetic expression of the 22 pairs of chromosomes that all of us have, illustrated with different combinations of letters and locations that suggest various mutations that have been found more likely to be in a Parkinson's disease patient than in the general population. And these are coded by the blue ones, genes that definitely cause Parkinson's disease, genes that are mutations that are not normally functional elements of our DNA. There are also genes pictured in orange here that contain moderate risk effect. That is, they increase your chance for getting Parkinson's even if you're not inevitably going to get it because of that gene mutation. And then there's some others portrayed in black letters for whom these definitely pop up in somebody in a population, that is, with Parkinson's disease, but not so much in the general population, which are associated with the risk for it, but aren't necessarily causative. They just travel with the disease a little bit more. And this picture of genetic risk factors is very important because although we think of this disorder as being largely sporadic, perhaps it has more genetic underpinnings. And this would be good news in one sense because the genetic revolution has allowed us to come up with a number of therapeutic approaches that we will have to explore in the future, for example, with techniques like gene editing or gene therapies. And here in this next slide is that same diagram with the lines drawn that suggest that the various gene mutations that were shown in the last slide sometimes have an outcome in terms of proteins that are abnormally created by that DNA, and these may have some therapeutic implications. If you can shut off that protein's production, for example, perhaps that risk factor might go away. And so this is sort of the hope of the genetic revolution in Parkinson's disease, as it has been for many other human disorders like cancer and so on, because genetic findings may lead to therapeutics of the future. So I'm further complicating your mind at this point with the story of how complicated the genetic story has led to understanding about Parkinson's disease. And portrayed in this cartoon are a number of structures of nerve cells, cells throughout the body, that can be impaired. If you have, for example, the DJ1 mutation on your genes, perhaps your mitochondria, the energy factories of your brain cells and elsewhere, might be malfunctioning. There is evidence for this. There's evidence for other things, such as the metabolism of proteins or protection against oxidative stress throughout all of these genetic mutations. And it may be that there are consequences that are lifelong from having mutations that will take a lot of sorting out to see if these lead to therapeutics. And of course, most patients who have Parkinson's disease don't have genetic mutations or testing that will bring out why they have Parkinson's at this point. And it's not clear that all of these phenomena that are going on here are necessarily pointing us to the cure, but they've been very important steps in understanding this disorder and giving us ways to plan for the therapeutics of the future. And finally, we have here how the cascade of understanding Parkinson's might be envisioned in future therapeutics based on what we've gone over. For example, there are sporadic cases of Parkinson's disease, but they may share mechanisms with the genetic forms shown on the right, which are familial and in some instances might have implications for other family members to be treated because they have an affected family member. At the present time, we really don't have a therapeutic strategy for what to do with the brothers and sisters and cousins of somebody with Parkinson's, but in the future it may be quite relevant to be tested and looked upon increased risk if you have the form of Parkinson's which conforms to the familial forms. So here it's just listed the various kinds of testing, some of which can actually be commercially run these days. But I would encourage you not to look upon these as necessary tests to carry out because we, at the present time, don't have implications for how to use this data in terms of treatments. And finally, let's look at another tool that we have for doing research. The disease as a progressive disorder is well known on clinical grounds, but using a particular kind of scan of the brain which is commercially available called the Spect Scan, we can see sequential changes that might guide us as to whether a particular protective therapy, something that's being sought for in research even right now, might be effective. And so you can see from left to right decreasing intensity of that central red structure that indicates dopamine function in the brain. This is a sequence of events over 5 years in a typical Parkinson's disease case, showing that we could monitor those changes and perhaps, if we have a useful interventional therapy to slow down the disease process, see it in the brain scan long before even the symptoms might announce what's going on. So in this talk, I've tried to indicate the kinds of things that have changed the identity of Parkinson's over the years. We have a large challenge ahead of us to deal with the disorder beyond the things that do respond to medications. I've listed here just a smattering of the various kinds of unmet needs of Parkinson's disease that don't have good therapeutics with them, and really we have a lot more to learn of where in the brain these problems come from. For example, many people with Parkinson's disease have impaired balance or forward flexed posture or disturbance of blood pressure and involuntary movements of various sorts. All of these aren't really well understood where they come from, why they're there in some patients and not in others, and why they have such a challenge ahead to control. And finally, Parkinson's disease, the same changes that affect the nerve cells to make the motor disorder happen, can also affect other parts of the brain. The alpha-synuclein that makes the tremors occur can also interfere with cognitive functioning, so impaired short-term memory, other aspects of thinking can be a feature of this disease, and fortunately, whatever cures Parkinson's disease, the motor disorder may be helpful for preventing dementia or other aspects of cognitive disease. So finally, I'd like to finish on the note of the notion that there are syndromes of dopamine deficiency that are due to toxins, and if we're lucky someday, we'll be able to block a toxin like MPTP, which is widely used in treating Parkinson's disease in patients who've been exposed to this. So in this short talk, I've tried to overview a great deal of information, of evolving information about Parkinson's disease and its changing identity from what James Parkinson described back in 1817. The story is going to keep changing from time to time, and in fact, even next month, there'll be a flurry of new information about Parkinson's. I can be sure of that. Appreciate your attention to this talk and look forward to your questions.